we need to do a much better job of embracing that piece of evidence and wisdom into our future. So today, Anne has said, we're going to hear from two Indigenous leaders, and that's a very important part when we're thinking about equity. I'm just going to shine a brief light onto another group. Anne has mentioned already the elderly. We cannot be very proud of what we did in Canada with respect to older Canadians. And I'm going to talk briefly about the immigrant newcomer community because it's another group of underserved, marginalized, whatever term you might like. So that just one more. And there are many others, including now we're really realizing all the unintended negative consequences of our actions during COVID, mental health, suicide, domestic violence, and many. So with respect to this, the little vignette I'm going to share is based on another less proud moment for Canada, is due to an outbreak at a meatpacking plant in High River, a town south of Calgary where I live. In the early phase of the pandemic, it was the largest single outbreak in North America at the time. So just a couple of facts about that. First, why I'm interested. I have a friend who originally is from the Philippines, and she called early days saying she was recovering from COVID. She was very ill for 10 days, but her family doctor had called her every day to see how she was doing and check up and give advice. And I'm going, really? Like, that was unheard of to me. I'm going, how, what led to that? But she had a contact that worked at the meatpacking plant. So High River is a town of population 13,000. There was 2,000 employees at the Cargill meatpacking plant. 950 of those employees ultimately tested positive, and if you counted their family members and household co-livers, it was 1,500 people who tested positive. 2/3 of the staff at that meatpacking plant were considered immigrants, compared with 25% quarter in Alberta overall. These employees tended to live in multi-generational homes. 2/3 of them actually lived in Calgary, so they carpooled every day to work. And most of them didn't have any choice but to go to work because of financial pressures on their often large families. So with respect to that, the approach that I'm going to talk a little bit about in High River, the professionals who were involved deemed their approach to the early phase, pre-vaccine, to be successful. And what were their metrics? They thought they might have 10 to 20% of their positive clients end up needing professional care, ER or hospital. Their hospitalization rate was 1.8%. So, and other than a swab to get a PCR test in the early days, 98% of all the people who tested positive never saw another health professional face-to-face. So I'm going to talk a little bit about that experience in High River in two periods, really, the pre-vaccine period and the post-vaccine period. I was not personally involved other than hearing from my friend. So I'm a member of the public in this regard. Imagine under Dawn's leadership and working on behalf of Anne and her team, did some work talking to people across Canada, asking about their experiences during COVID that would inform supply chain. That was in the early days when supply chain didn't run off our tongues at the dinner table. We just didn't talk about it. Now it's very different. So Dawn and the team went out and talked to people about their lived experience during COVID, and they came up with 5 themes from the work. And So this report is available. There's the cover, but those are the themes that are there. So I'm going to talk about those themes. This work was done kind of concurrently. It was just before the vaccines dawn and early vaccine months, January, February. So it was kind of concurrent with what was happening in High River. And so they found these themes. So I'm going to just reflect on those themes. With respect to the High River case study, there was no connection. They were happening independently. So the first three themes, lack of trust, which was the biggest theme. People didn't trust the government. They didn't trust information because it changed constantly and the rationale wasn't clear. Government statements seemed to value some lives more than others, i.e. the elderly would be the prime example. And this one-size-fits-all approach, which I think we could all, in Alberta at least, identify with. You know, these were the rules and the guidelines, and that's what we could do this week or next week. So with respect to High River, the professionals involved, based on pre-existing positive collaborative relationships, immediately recognized there could be a huge challenge ahead. So they acted quickly. The professionals working together came up with a care pathway for the Calgary area. When the first case hit ER, the people went into action right away. So the care pathway involved some aspects which I think were really important. First off, the team assumed, and they were transparent, they assumed that the pandemic was going to be mild or moderate kind of impact, and that people could be cared for in their homes. So they went in with that assumption. The care pathway involved, for every person testing positive, and the town and the primary care network set up a pop-up testing clinic 3 days ahead of Alberta Health Services getting organized for the bigger, more comprehensive. But they set up a testing site in the town within days. Everybody who tested positive got a virtual contact from a primary care team, their own doctor, if they had one, or another practice who said they would take new patients. In the triage that they did over the phone, they had, in addition to all the physical symptoms, which you all know more than me, they also had safety net triage things like, are you socially isolated? Do you have caregiver support in the home? Do you have food? Do you have a way of getting food? The bottom line is they learned very quickly they had to treat the household, not the patient. They had to treat everyone living under the roof. They gave very concrete information about how to safely isolate people. They connected them to community services to get food deliveries. So they gave consistent, helpful information every day if the physical condition of the positive person warranted it. So they had, probably no doubt, as a smaller community, they had very good knowledge of who was in High River. So that worked very well. So the early phase, as an observer, I would agree, they were quite successful. When you moved into vaccine stage, I think the story was not quite as positive. In the first stage, pre-vaccine, they took care to the people over the phone, but they took it consistently and specifically. When the vaccines were available, the mantra was, come to us. We have appointments, we have clinics, etc. So there were lots of barriers to getting there. Shift workers, people who couldn't leave home, all kinds of things. Didn't have public transit. So at that point, citizen input involvement, as our team heard from people not in High River, there was a firm belief among the people that we talked to that if they had just involved more citizen input, you could have avoided that one-size-fits-all. People felt they didn't get help for them in their situation, whatever the complicating factor was. It just didn't align nicely with the clear rules that were being given. So, and on top of that, and this panel is about this, all the pre-existing health issues and challenges that are still around, and which this community of practice, our role is to play hopefully a big part in keeping the focus on good outcomes and processes for all Canadians, not just people like many in this room. So with respect to supply chain, there were supply chain issues in the classic sense, the tangible assets. The masks were hard to get, but their approach actually reduced the need for masks because staff never saw people face to face. So kind of a good side benefit. They, as I said, worked with community. The workplace, which was forced to close temporarily, added plexiglass dividers. And some of the decision influences, which I think were important, and we've heard many of them from the panels this morning, but in this case, the care pathway was clearly a tool. The workplace took steps based in large part on union pressure and influence and feedback. Regulatory frameworks were not top of mind, but were identified as, those workers may not have had a safe, low-risk way to alert people about safety hazards. So that's potentially a regulatory thing. And of course, community agencies. One of the physicians involved in the Calgary community, where 2/3 of the people lived, said that the collaboration of newcomer serving communities in that part of the city was absolutely critical in meeting the challenge of getting vaccines to people. Sorry, that was... So that's, I think, although done concurrently and not one to inform the other, they in fact did come together quite nicely. So lastly, what is our role in this community of practice? It is really to create a forum for people with that being their primary interest, equitable outcomes for all Canadians. So that will be our kind of touchstone, if you like, and to ensure our collective efforts actually lead to more equitable outcomes. So we will be inviting individuals with diverse experience, and I invite all of you to think about people who you know or know of who may want to join in our citizens or our people's forum to help us learn. We are not experts in EDI. We, like everyone else, are trying to get better at it. So we need to learn together. And so you can help by identifying, and this is kind of a schematic of what we hope will come to pass. We'll have a forum that involves, I don't know, there's no set number, it won't be thousands for sure, but in an ideal world, we would have 2 citizens embedded in each working group. We're volunteers, and it's always helpful to have some backup and a broader perspective. So ideally, we'll have 2 in each. So that's just heads up. We'd love to hear from you, but we'll reach out if we don't. And we'll also have some people on our mothership forum with particular expertise in equity and diversity and inclusion to help us all. And you may well know people with that expertise too. So please do be in touch, and we look forward to working with all of you. Thank you.
So So thank you very much for inviting me and an Indigenous perspective to participate in this discussion. And I'm also very thankful that it's not tokenism, as there's two of us on this panel, and it always feels good to be someplace where you're in amongst more of your kind, and I mean, obviously, kind with respect to this. Like, we share lots of attributes as Canadians here in the province, as Albertans, and of course, with Bonnie, Indigenous roots and that. I want to talk to you a little bit today from a different perspective than Judy and Bonnie will. Because I think they're going to talk to you a little bit more about the equity from an outcome perspective with respect to health outcomes. And of course, many of you are already well aware of the fact that within Indigenous cultures, like some other cultures around the world, the healthcare is seen much more holistically. It's not about just care of acute conditions, but rather, a whole lifestyle and living. And one aspect of that obviously is that feeling of inclusion and participation, and of course that clearly involves economic opportunities for Indigenous people. And as you think about supply chains, I really want to encourage you to think about how Indigenous partners can be involved with respect to those supply chains. First of all, a little bit about our organization, the Canadian Council for Aboriginal Business. We're roughly 40 years old. We are national in scope, head officed in Toronto, and formed 40 years ago. Local story with respect to that formation. The idea came about from an event that happened in Calgary, and if you want to know about that, I would encourage you to check out our website and hear the story of how that concept came to being. We are a member organization, not for profit, in some ways similar to a Chamber of Commerce for Indigenous businesses, but we're not exclusive to Indigenous business. Roughly a third of our membership is non-Indigenous, and but unlike a chamber that votes on all of its positions and that, we don't quite operate that way. We do have a board of directors that helps guide what we're doing and that, but we really are self-directed to a degree, and with respect to where we believe we can provide service and support to those businesses. And we've grown quite significantly through the last number of years, and part of that, I think the pandemic was helpful to swelling our ranks to a degree. We have a number of key programs for our members and for non-members that might be interested in joining us. One of those is for non-Indigenous businesses and perhaps organizations, our Progressive Aboriginal Relations, which helps develop the right culture within your workplaces and that within your ventures towards incorporating and understanding Indigenous communities and getting their good work in a good way with respect to those communities and that. We also are involved in certifying Aboriginal businesses and providing tools and financing for Aboriginal businesses to help them get started and mentored and that with respect to their involvement in the economy. We do research and help shape public policy, and as well do a little bit to celebrate the achievements and that of Indigenous peoples and Indigenous businesses in the commerce space. The Indigenous economy is significant in Canada, of course, but there's also a significant gap between outcomes within Indigenous communities and the broader Canadian society. And closing that gap would be significant to all Canadians with respect to understanding how impactful this would be. Estimates of around $28 billion, which is equivalent almost to one of the maritime provinces' incomes, and that. So getting Indigenous peoples involved in the economy, very significant, right? We are the fastest growing population base within Canada. We represent about 5% of the population here in Canada. But significantly, we are a young population, and we are entering into the workforce in larger numbers. So creating opportunities for Indigenous youth to participate in the economy is going to be tremendously important with respect to social outcomes and ensuring a better future for all Canadians with respect to removing some of the social problems that exist within First Nations communities and Indigenous communities in general. Right now, roughly 4 out of 5 Indigenous communities across the country have median incomes below the poverty line. And, Indigenous youth are far more likely to be involved in growing up in an impoverished home. But also we see that the reliance on social assistance programs for Indigenous communities or individuals living within Indigenous communities and Indigenous people is growing, right? And that's not a great outcome for any of us, right? Obviously, we all, as individuals, would prefer to be productive members of society and not be reliant on social assistance programs whenever possible. Of course, healthcare, your industry, is big business. $300 billion, I think, is the total that's being spent on healthcare in Canada. And so that's a huge playing space for providing prosperity for Indigenous entrepreneurs and Indigenous communities. Right now, though, Indigenous businesses tend to be small businesses. Few of them have more than the owner. But there is tremendous opportunity because Indigenous businesses span across the entire landscape, the entire economy, with respect to what Indigenous entrepreneurs are involved in, right? It would surprise you to know that they're in manufacturing, food processing, personal protective equipment is also something, and I have a list of members that are involved in that if you're interested in getting that from us. Indigenous people, though, are people of abundance and are tremendously resilient. I mean, had to be to survive under the conditions that have been forced upon Indigenous people by settler society and settler conditions. And so we find this over and over in our research in terms of how often Indigenous businesses innovate, introduce new products, are quick to adopt new technologies. And so they are great partners to contemplate with respect to getting involved in what you're doing. Governments have pledged as part of economic reconciliation to include Indigenous partners in the economy. Right? We've done some work that illustrates that Indigenous businesses can supply quite a bit more than what we're given credit for. Roughly 24% of all federal procurement is something that Indigenous businesses could take on. Right now, the federal government and many provinces have targets of roughly 5% of spend be from Indigenous businesses. Very achievable. However, right now, as far as government spends go, we are probably trending in close to 1%. So, you think of 5% of the population being Indigenous, and yet they get 1% of government business. Your networks will be an important aspect of that, because if Indigenous businesses and entrepreneurs not involved in the supply chain for healthcare, it'll be very hard, given the size and magnitude of that in provincial and federal budgets, for that target of 5% to get realized. And so there are a number of things that can be done. I think the first and most important is to take an inclusive approach and recognize that inclusive approach is not a paternalistic one of identifying, yes, we need Indigenous businesses, Indigenous communities involved in this, and so we will carve out a place for them, but rather to bring them to the table. And I think this goes a little bit to some of Judy's comments about the importance of having the communities themselves involved in the discussions early as opposed to late. Effectively communicating what it is that you're looking for in your procurement. So where are the opportunities for businesses to participate? Being clear about having minimum requirements that some of your spend will go to Indigenous businesses, and holding firm to that. Ensuring that there is that slice available. Being cognizant that many of these things take capacity building time and require investment, training, and development, and recognizing that is a long-term payoff aspect. And of course, encouraging your current suppliers and members within your supply chains to also enact these standards, to also involve and include Indigenous subcontractors within their efforts. So I'll close there and allow you to hear from Bonnie with respect to the more direct community impacts within Indigenous communities. Right. Thank you.
Do I need to advance? So Bonnie, I think we are over to you. I'm just looking for you on our, there you are. Welcome, welcome. Can you hear us okay?
Oh yeah, I can hear you.
Excellent.
Okay, my name is Bonnie Keeley. I'm from the Kainai Nation, Southern Alberta. My own community has roughly about 13,000 members, and as the health director for the Confederacy, I work with 3 communities on the Canadian side and 1 on the American side in Montana. So roughly about 45,000 Blackfoot Nation members. Just to give you some background, my background is nursing, and for the past, I guess maybe 15 years of my 32+ year career in nursing, I've been working with chiefs in Alberta and Canada, and now more concentrating on working with Blackfoot. So this next slide is just an overview of what it is that we're trying to address. So I'll just advance it to the next. So when I was looking at health equity for the pandemic, and I partnered on a study looking at racism in the ED department, you want to go back to the health equity slide, sorry. So the article is published, you have a screenshot of it. But what I didn't want to do, because I'm also a trained nurse from, working in the ED department, so trauma trained, and did my ER nursing in the University of New Mexico in the US. And when we looked at racism, I didn't want to look at it the way that, I guess the hospital in Winnipeg looked at the Brian Sinclair incident, and where they spent over $150,000 to prove that racism wasn't at play with the death of Brian Sinclair. And for those that are not familiar with him, he was an Indigenous
Thank you so much, Bonnie and Matthew and Judy. I think they've given us many, many things to think about and opportunities. And I'm very happy to have questions, thoughts from anyone in the audience, and perhaps just to get us started. There are many options and opportunities here. Each one of you on the panel have suggested the ways forward. If you were to advise this community of practice and the many decision makers that we collectively could potentially influence, what would you say are the critical next steps, which is a bit of a prioritization question? I have to say, in the many health system leaders I spend time with, outside of Canada and inside of Canada, they all ask me that question. So we get it. Let's assume they get it. That's carefully stated. What should we be doing? What might be next, given what we know today and what each of you have shared with us? Bonnie, any thoughts? And then I'm going to ask Matthew and the Aboriginal businesses and Judy. Any thoughts if you were to say, look, if we were successful in doing one or two things next, which won't, of course, solve it all, what might be those one or two things from that Indigenous perspective? Judy or Matthew, any thoughts? And by all means, just a signal if you have a question in the audience.
I think the answer to that is to be inclusive.
Yeah.
And to not assume the answer without engagement with the communities. And I think specifically to Indigenous communities, but not exclusively, right? And I think that's so critical that everyone is involved through all aspects of the supply chain, healthcare delivery, all of it, but involved in setting the priorities and setting the outcomes and setting the pathway as well. And that involves capacity building.
Yeah.
Right.
Yeah, no question. In many ways, when you start to link a few things together, that data, as Bonnie's suggesting, creates the transparency that actually ties to trust. If it's more transparent, then you can at least know what the parameters are you are working with or the outcomes you're trying to achieve. I don't think the data systems and infrastructure has allowed for that. One of the first papers I wrote in this whole study was called Flying Blind. Like, we were literally making decisions every day without any data or instruments across the country in terms of managing a pandemic. So no question, but I think what we often forget is without that data, how you can't have transparency, trust, and communities building that capacity to make data-informed decisions, right? That are meaningful to the culture and the context of each community. Judy, any thoughts?
Interesting. I wrote down something immediately, which although it's stated differently, it's the same end game. I said we need to surface what outcomes matter to people living in Canada. And Bonnie and Matthew have both given examples of those from their specific communities. So it's not just outcomes for everybody, but it's outcomes in specific diverse communities, be they Indigenous, immigrant, elderly people who need support. We're not all the same. You know, one size does not fit all, which is what we heard. And so it's the data, transparency, and accountability to Canadians who pay the bills,
Yeah.
to be frank. Yeah.
Yeah.
Thanks.
I once upon a time worked very closely with children with special needs, and this young girl, about 7 years old, said to me, "Hey, lady, nothing about us without us." I've never forgotten that. And that was like 4 decades ago. Hate to admit that. But it just strikes me again, nothing about us without us. Starting with the "hey, lady," that was the best part of it. Are there any other questions, thoughts, ideas, or perspectives before we close out this session? And then, yes, Adele, well, then we're going to move into our work groups.
Thank you so much. And that is exactly what Eva Hill, she used to be the chief of Six Nations, told me as well. Nothing
Is
about
that-
us without us.
yeah,
So
it's
she's
so
using that
true.
all the time. So my question is on the other way around. I think is we in your presentation, especially Bunny, but receiving actually the healthcare services. But in my conversation with many Indigenous people, is they want also to decolonize the approach to healthcare and what we can learn about how to deliver health and well-being, and in this context of also I think sustainability in our relationship with everything that is around us. So I think there is a lot that we can learn and how you can drive this kind of now approach to health, because healthcare systems, at least the Western way, is not healing like we are dealing with the symptoms, but really dealing with the foundations of the problems. So this is one. The second question, I always have a hidden question.
I might have to cut you off, Adele.
Sure,
I'm just
very,
kidding.
very quickly on this one is the problem of governance. And one of the difficulties with Indigenous kind of delivery of care, you have this kind of fragmentation of governance between different nations and so on. How do you think that that should be resolved when you start talking about delivery of care?
Yeah, it's a good question. Matthew, Bonnie, invite you to.
I can make an
Well, I think to add to that, if it's possible to add to that, that wisdom of recognizing that healthcare is a holistic and needs a holistic approach. I think we are seeing and understanding that more and more. And Indigenous cultures, not just within Canada, but in other parts of the world as well, seem to have a much better grasp of that holistic approach to health and wellness. And so adopting that into a general framework is going to be helpful. And to the second question you asked about fragmentation, Canadians have to accept it, right? We're dealing with not Indigenous people, not First Nations people, Inuit and Métis people. We're dealing with hundreds of individual communities, nations, in and amongst themselves, and they needed to be afforded, we needed to be afforded the respect of that and be treated as individual communities, individual nations, and not assume that one size approach to Indigenous relations fits. Having Bonnie come and speak for all First Nations in Canada, having me come and speak for Métis or Indigenous people across the country is, it's a start, it's good, it's better, but it is far from acceptable.
Yeah. In some ways, what we're touching on, and I'd love to have your thoughts on this, what you've described in Maslow hierarchy of needs, every nurse in this country in every nursing curriculum learns that verbatim, or you just don't get out of first year. So interesting. Bonnie, I'm grateful that you shared with me that it was actually based on Blackfoot systems, but we have a health system that doesn't, even though we're all taught that doesn't see the whole person. Mm-hmm. We are a reactive health system that waits for you to get sick, then we diagnose you, then we put you into these clinical pathways, which, and by the way, are one size fits all, based on clinical trials that represent very few of us, and then we expect good things to happen. It seems backwards. So in many ways, in my mind, what we're talking about here is shifting and driving a system towards the whole person. Tell me what your health goals are, and then I as a nurse or physician, whoever, have a much better opportunity to know where I can help you reach your goals that are meaning to you within the unique context and circumstances that you live, rather than the ones I live or the health system puts you into, for example, in these clinical pathways. That's a much bigger agenda than a supply chain, of course. Not for the faint of heart either, but think about how that supply chain infrastructure and glue that JP talks about now becomes the strategic asset, potentially, to advance that. We made allocation decisions based on not very much evidence that I could find, but I'm happy to be wrong, and please tell me. What if we made those decisions based on risk profiles? Bonnie, that's what you just shared. They switched from the risk-based, who do we protect first, and make sure get that vaccine and on down the line, as opposed to, oh, well, you better protect the system. That's a little like putting all the PPE in the hospitals only for our communities and long-term care centers to, all the best, which didn't turn out very well. So these are very fundamental perspectives and assumptions, perhaps, that I think this is an opportunity for us to question and to really ask, so back to your question, Judy, what are the outcomes that are meaningful? Well, what I would say is meaningful may be quite different than Bonnie or you or Matthew or Nancy or anyone in the room. The question is, we have to start to ask and open that up, because we've spent far too long. Even though we all learn Maslow's hierarchies of needs, then we go put these nurses into these systems where that never actually shows up in a chart. Almost, literally. I'm a hospital-based nurse, so I may be wrong, But I think it's the fundamental opportunity here to shift towards how do we create those conditions for every person to choose the way they wish to realize their health potential. And if that is a goal and that's how we define equity, and that's just a suggestion, and from when I pull all these pieces together, then that's really an opportunity where supply chain, nobody would have suggested prior to the pandemic that supply chain had a role to play. In my mind, it's like central to this agenda, but call me crazy. Matthew's already heard this before, but think about those opportunities. Just even to start to have that dialogue, in my mind, is, I think, really one of many reasons I think we're all here. Any other last comment, question, thoughts, tall order, outcome that's meaningful? Yes?
I want to personally thank you for the invite, but I do have to run.
Thank you ever so much for joining us, and join me in thanking the panel for a great discussion today. So now is the time where we have the opportunity, I think, to go to a more detailed, perhaps, dialogue and discussion in the work groups. When we proposed the structure for this community of practice, although it does appear that we are trying to solve the world's challenges, we are really zeroing in on where and how supply chain resilience can drive towards equity in health systems. What we've done is, as you know, is it on are the work groups on the slide? It's just changing over? Okay. There are a total of 6 work groups, but given some challenges with work group leaders being able to be present today, we've had a few become ill and many other challenges come up. What we've done to try to create a balanced representation, and forgive us if you, I put some of you into work groups that you may not have selected, but my goal was to do a few things, to bring multiple and diverse perspectives to each of the conversations, to balance, if I possibly can, if you had 3 people from one organization on one group, bringing that organizational expertise and perspective across 3 groups instead of 1. So you'll see your name, hopefully, on one of the work groups. You'll notice leadership and policy has been combined with workforce sustainability because our chair of that work group was unable to be here, so I'm going to navigate those individuals. You will stay in this room for that first, the leadership policy, workforce sustainability. On JP's is leading sourcing, procurement, collaborative stockpile. He will be just outside the door in the, it's like a seminar room. And then digital supply chain security with Christian. Maybe I can just introduce our workforce leaders. Colleen Medj. Colleen, University of Manitoba, she is leading digital supply chain work group. She's going to gather her group in the cafeteria, correct? Christian Leprecht from Queens, where are you? There he is in the back. Christian is leading supply chain security and sustainability. JP, we all know, he is going to be just out there. And did I miss anybody? I don't think so. Domestic, oh, Ron Johnson. Ron? Ron is leading the domestic supplier network sustainability, and they meet in cafeteria as well? Cafeteria as well. If you don't see your name on a work group, join the work group you would like to join. And we will be thrilled to have you. And we will, if you can move to those work group sessions now, what we're really after is to look at and start to talk about what will each work group start to take on. What are those scope in terms of reference, workforce, I'm sort of the work group plan, basically at a high level. And that's what we'll report back to the larger group at the end, which is 2:45? Yeah, 2:45. Christian, yes. Where's Christian's work group? Follow Zena for the, yes, Zena's assigned to you security and sustainability work group. 2:45? 2:45 or? Oh, it's 2:20 now. That's not nearly, so we'll be quick. Let me see. How about come back in 1 hour? 3:20? Yeah. 3:20. So we'll have to quickly solve all those challenges.
Thank you very much, Anne. I have to run.
Do you? Okay.
Yes.